Hello, my name is Dr. Shayan Safar. I am a doctor of physical therapy, a board-certified orthopedic clinical specialist, also faculty at Cal State Northridge's graduate program in physical therapy, and I'm also a Hollywood stuntman and a Brazilian Jiu-Jitsu black belt. About 4 weeks ago, I tore my Achilles, and so today I wanted to talk to you about some of the early principles in your rehab to make sure that you are doing this right. All the stuff I'm telling you moving forward are general guidelines. However, everyone's care is different, so please consult with your surgeon, your physical therapist, because the quality of your tendon, the way it tore, your context, everything matters. So these are general principles, but these are not necessarily specific to you. This is actually one of my favorite surgeries to rehab, and the entire medical community has learned a lot over the past 20 years about the optimal way to rehab this procedure. It is a long recovery, so there will be some patience and discipline needed. So let's get into the things that will help you make the most of this journey. The first and foremost, most important principle, non-negotiable, is in the first 12 weeks, we are not going to stretch that tendon at all. When an Achilles tendon tear happens, you can think of it as if it got overstretched and separated, and during the surgical procedure, they tighten it back up. And if we stretch it too soon, it will become permanently loose and we will have strength deficits forever. This is a really big deal. Whether you're an athlete or someone in just day-to-day life, if that tendon is loose all the time, it will make your life in whatever athletic sports much harder. We will get into the specifics of what that looks like to make sure that we're all very clear about how to not stretch this. But we're also going to get into some exercises you can do to start facilitating some of the healing of that tendon, building your calf muscle strength so that you can get ready to return back to day-to-day life and the sports when the time is appropriate. The first thing we're going to do is actually strengthen the other side. This might seem indirect, but here's why. There are some studies that show that when we work on the contralateral, meaning the non-affected side of the injury, it helps minimize atrophy when we're having surgery or injuries on the other side of our body. And secondly, when we start doing our return to sport testing, we're going to compare our affected side to the non-affected side. And if our uninjured side has been kind of resting and dormant for 3 to 9 months, depending where we're testing in the rehab, we might get some false sense of security that our injured side is really strong because it's competing at the level of the non-injured side, but really the non-injured side has been resting and doing nothing for so long that we're not really getting a true baseline of its capacity. So you'll do single leg heel raises on the unaffected side. Now there's a number that you're going to shoot for based on your age category. These are the normative values for how many of these single leg heel raises you can do based on your age. And you can look at that graph and aim for that number. A couple key details. When we do this testing, we put a metronome on to the beat of 60 beats per minute. You can use your phone or a metronome. And the idea is you're going to go 1 beat up, stick it at the top, 1 beat down. You can use your hands for balance on a table or the wall, but don't put weight through your hands because you're essentially cheating. Other ways we can cheat is by flicking your knee up, raising our toes and putting them down to swing and get momentum. We want to minimize that so we can build the capacity of our unaffected side. Secondly, we're going to work on the hip abductors, mainly your glute muscles. There is a ton of research that shows that getting strong hip abductors can reduce a lot of stress on the entire lower extremity, meaning your legs. This is because it's the base of the pyramid of your legs, and if these are weak, you're going to have to compensate the entire chain. The problem is, because we've been non-weight bearing for some time, this muscle is likely getting weak, and it's also going to set us up for some failure. So we're going to go ahead and start strengthening this with a TheraBand. You'll lay on your side, you'll put the TheraBand above your knees, and you're going to go ahead and practice either a clamshell or a sideline leg lift, making sure we're really focusing on good glute activation. There are some subtleties in how to do this to make sure you're using your glutes, and if you're not sure, that's where speaking with a physical therapist, reaching out to me is very helpful. Now, we're gonna get into the nitty-gritty of starting to do some exercises for stimulating the Achilles tendon. As I mentioned before, we are not going to stretch it, and that is a true non-negotiable in the first 3 months. Stretching the Achilles tendon looks like dorsiflexion, which is essentially when your toes are coming up towards your shin, or if your foot's on the ground, your knee is going over your toes. The Achilles tendon is on slack when you do plantar flexion. You can think of pointing your toes like a ballerina going on toe point. And so in the early phases, we want to avoid that dorsiflexion. And most of the time, it looks like your knee kind of rocking over your toes. This is probably why you have a heel wedge in your boot, or you might be in the Vacoped, also known as the Kobe boot, which kind of keeps your foot at a resting plantar flexion tension so that we're not rocking our knee over. And this is really important to stay true to those precautions that your doctor gave you, meaning don't take those heel wedges out early, don't start walking barefoot in your regular shoes too soon. We can always get that mobility later, but there is a critical window that if we stretch it too early, too soon, we will have permanent strength deficits. However, we also need to push it a little bit so we can start building strength and stimulating that tendon. So let's get into the nitty-gritty of how to stimulate that Achilles tendon without putting some stretch on it. One of my favorite exercises to do early on is a seated heel raise. You will get a heel wedge, and you can buy one of these on Amazon, or you can use a book or a plate to put under your heel and your foot on the ground. So that way, if you don't have the money or access to one, there's still plenty of ways we can get creative. This way your foot is in plantar flexion, so Achilles tendon is not being stretched, and we're gonna go ahead and do some seated heel raises. However, before you begin, this is a very important note. Where you put the heel wedge in relationship to how close it is to you on the ground is very important. Because as you can see, and I'm gonna demonstrate this on my non-affected foot because I don't wanna stretch my fresh Achilles repair. If I bring the heel wedge closer to the chair that I'm sitting in, my knee is getting closer towards going over my toes, and I'm effectively stretching this Achilles tendon. The further my foot is away from the chair, meaning the more straight my knee is, the more my foot has to plantar flex to match the surface of the ground. And so when you're doing this seated heel rise, first what you want to do is have your non-affected foot relaxed. See what resting tension is, and I want you to put it on the ground where when you put it down, without any weight, you see it kind of touches flush. Your toe doesn't go first, your heel doesn't go first, it's flush. And then you're gonna scoot it forward. Then you're gonna do the same thing on your unaffected side, but you're gonna go even a little bit more forward than that. You should have a little bit more resting tension in the affected side straight out of surgery. Injured side should be away from you, meaning your knee should be further straight. Then take that foot off, so we don't put any weight on it yet. Put a heel wedge there, and then put your foot on top of that heel wedge. You're gonna be at the very end range of your plantar flexion. So then you're gonna do some seated heel raises, and there might be a very minuscule amount of movement, which is excellent. That's what we want early on. This is the end range, and honestly, this is where people usually are the weakest after this recovery. Partially because if that tendon gets stretched, it's really hard to get that end range stiffness. And secondly, our muscles are what's called under active insufficiency, meaning they're so tight together, it's hard to generate strength. But we need to spend a lot of time here to get that strength back. What you're gonna do is just have your foot resting on the heel wedge, then go ahead and just do a little pulse up as high as you can. If you're not sure if you're reaching your max height, you can have your other foot match it and then go up with both and compare side to side. And if you're not sure, try to reach a little higher. You want to go as high as you can and really squeeze at that top. You can aim for those same normative values, like I said, for your age group. For instance, if you're in your 20s, you can try and go for in the 30s to 40s repetition, getting a good squeeze at the top. When we're progressing the seated heel raise, what I encourage you to do prior to getting more range of motion by scooting the heel wedge back is actually adding some weight. I would rather add 5 pounds, 10 pounds, and work on that end range before we bring it closer and stretch it more. As we go more weeks into it, we'll start bringing the heel wedge closer. So we're still in plantar flexion, but we're starting to get a little bit more range of motion without stretching the tendon. But first, add some weight. It's really important that you feel your calf contracting during this. And if you're not sure, because early on your calf might have been kind of quiet for the past few weeks as it's been in the boot or cast, what you can do is take your finger and push into the belly of your calf and feel it contract and push back in your finger. This is a good way to start building your brain to feel that calf contract. As we progress, we want to build more weight, bring the heel wedge slowly closer, because there is some research that shows at 12 weeks, we want to be able to do at least half our body weight with that single leg heel wedge, meaning I'm 150 pounds. I'm going to work my way up to a 75-pound dumbbell or barbell on my knee as I do those heel wedges. This is a really good predictor of you being able to do a standing single leg heel raise. Lastly, another option for this early phase is pool therapy. The pool is an excellent way of taking gravity off the equation. And I encourage you in the pool to still use one of those heel wedges. This one I got is rubber, so you can get wet and doesn't get affected. This way you can still work on strengthening that calf and we're not gonna bottom out and stretch that tendon. Also, if you're in the pool and there's a little slant down, that will help too, because it's gonna basically help your foot be in more plantar flexion versus if you're on a slant up. So be careful, because if you're near a wall and your foot is kind of resting on a slant up, you will be stretching that tendon. We don't want that. So make sure if you're standing next to a wall, you may need to face away from it or have something else to hold on, because you're gonna use your hands to take some of the weight off. But use a heel wedge, take it within you. I've also made water shoes and put heel wedges in it, but Currently, my foot is still swollen and too fat to fit in there, so I just use the big rubber heel wedge. Make sure you don't stay in there too long. We don't want that incision to get too wet and start getting weak. Again, consult your surgeon about the appropriate time to be in this and making sure you're safe to do it because we don't want to risk infection. That wound needs to be closed and healed before starting this. These are some of the early rehab principles that you're going to do in the first 6 weeks. Different surgeons have different protocols on weight bearing, but for the meantime, these are 4 things that you can do to start working on your Achilles journey without putting too much risk on the tendon.